But yeah, we're basically doing diabetic emergencies today, and we're just going to be talking about the three big ones, which is DKA, diabetic ketoacidosis, HHS, hyperosmolar hypoglycemic state, and hypoglycemia. If you Google sugar mama, this comes up as the first image search. And I think it's some cartoon on, I think it's a children's show, but I'm not sure. I didn't get to look into it. But the subtitle is "Don't ever forget glucose." As with all problems, we want to be able to define what the problem is so that we can identify it properly, seek the cause, treat the pathology, and then manage the complications of the condition and the treatment. So just kind of keep that framework in mind as we go through this. Here's a case, pretty typical. 17-year-old female, otherwise healthy, intractable abdominal pain for 2 days, vomiting, looks unwell, dry, breathing up, it's tachypnic, has a rigid abdomen, referred to surgical for acute abdomen perforation. After some treatment with fluid and analgesia, the nurse dutifully checks the BSL. It's high. This is a pretty common scenario of ABC, then DEF, don't ever forget glucose. So, no points really for guessing what this is going to be. What is this going to be?
DKA.
This will be DKA, right? So just looking at the OBS chart, what are the main points of note?
It's very tachypnic.
It's very tachypnic. And then confirmed DKA with blood sugars and even high ketones. So high that even the ketometer didn't read it. So DKA is a bit like Beyonce, and I actually thought of Beyonce first because she has this really good song called Sugar Mama, which I'll play later. But it's because Beyonce's kind of everywhere, very aware of DKA. Like everybody's aware of Beyonce. You can't get away from her. Very rich, in a sense. But it's also very possible to get a bit blasé about DKA as well, because we've got a very good protocol for it, which is good. The management of this should be relatively straightforward for all of you, because we've got a very good system. But it'd be good to go through the pathophysiology so you understand exactly what we're doing. Her song Sugar Mama samples this song, and I might play it later if we have time. But like Beyonce, there's layers to DKA. There's layers. Alright, so let's define diabetic ketoacidosis. Can anybody give me the definition, sort of biochemically, of DKA? What are the criteria?
Triad, isn't it?
Kind of in the name. It is kind of in the name. What would the numbers be?
So, try to hyperglycemia,
Yep.
ketosis,
Yep.
and acidosis.
Yep. And anybody got any ideas on the numbers that make up that definition? I think it's a bit higher than that, but it's not actually super. It doesn't have to be super high, correct?
Acidosis less than 7.2.
Yep.
Ketone does no specification at 1
I'm trying to remember. I can't remember the ketones off my head actually. I'm not sure if there
I
is.
think you just have to have
Yeah,
ketosis.
you just have to have ketosis. So BSL greater than 13.8 is what's on our protocol. So it's not that high. pH of less than 7.3, as I say, or bicarb less than 18. Ketonemia, and then sort of in the protocol they've also talked about an ANR and GAP of greater than 10. We won't really talk about that. Oh yeah. So how does it happen? So let's just take away there's always a trigger of some description, but then what happens? how does the diabetic part happen? What's that do? Pathophysiologically.
Not producing enough insulin? Or is that what you mean?
Yeah. And is it absolute, relative, sum?
So type 1 is absolute.
Type 1? Yep. Okay. And then, so this happens after that. So you've got your insulin deficiency, which generally is absolute, which then also results in the release of a lot of stress hormones. Your body is not utilizing glucose, which then induces a stress sort of response with all these other hormones, including catecholamines. So we have a sympathetic kind of surge in response to this peripheral underutilization of glucose. And those stress hormones further antagonize insulin. So you get this big mix of this whole cyclical thing. And you get this persistent hypoglycemia, which then leads to an osmotic diuresis. So your urine has all this glucose in it, and as such your renal tubules then drag all this water into renal tubules. You pee out all this glucose-filled urine, you lose all this fluid, and that drags a lot of electrolytes out as well. Okay. What about the ketoacidosis part? How does that happen?
Because of, you're not getting glucose into your cells, your body's going to start breaking down. It's going to go anaerobic and also break down fats.
Yep.
So that's going to cause ketones.
Yep. So not so much anaerobic, but it searches for another fuel source. It starts to switch to fatty acid metabolism, and also ends up producing ketones as a fuel source. So this whole insulin deficiency business inhibits acetyl-CoA carboxylase in the liver. I had to look that up again, and that leads to an alternative fuel source, which is producing keto acids in the liver, and you produce two main ones, which is acetoacetate and beta-hydroxybutyric acid. The beta-hydroxybutyric acid turns up in the plasma, whereas the other two, acetoacetate, ends up in your lungs and your kidney. It's excreted, and that gives you that ketone smell in the breath, and that's what comes up on the urine dip, ketones. And then those keto acids dissociate in plasma and produce this metabolic acidosis. Yeah. Right. And so this is the gas of that patient.
I've got a quick
Sorry, question. Yeah.
Correct me if I'm wrong. You know, if someone gets sick, like infective symptoms, that can spark, type 1 diabetic, that can spark a diabetic ketoacidosis.
Yep.
Is that primarily mediated through the stress hormone pathway? And you mentioned that it antagonises insulin.
Yeah, so there's going to be some antagonism of the insulin, and then they may also not be dosing themselves as well.
Yeah.
So there's potentially two ways that insulin deficiency comes about. Correct. So this is gas. Comments? Katrina's face is like, whoa, that's a terrible gas. What makes it terrible?
pH is 6.98.
Yep, so quite a severe acidosis or acidemia. Yep.
Huge base excess.
Yep. Huge base excess. Bicarb of only 7, and your glucose there's 36. Any other comments? Any other metabolic or any other sort of disturbances?
So there's low CO2, is it
Yep.
trying to breathe it off?
Yep.
Breathe that fast.
Yep.
And the elevated potassium.
Yep. So potassium is also high on this gas, and we'll get to potassium in a bit. So the low CO2 often comes about because they're trying to blow off CO2 to buffer the acidosis, and that gives them that tachypnea and that Kussmaul breathing that's often described. So we've defined our problem: insulin deficiency, hypoglycemia leading to osmotic diuresis and electrolyte loss, and a metabolic acidosis. We talked about that, and this is just the nursing chart, just notable for Kussmaul respirations. Quite obvious when it happens. People just going like giants, huge breaths. So we've defined our problem, and so we'll move on to treating them. So we've got an insulin problem, a fluid problem, and an electrolyte problem. So we're going to replace our insulin, and it's an act rapid infusion, and it's going to be somewhere between 1 to 5 units per hour, depending on what the BSL is. Our protocol roughly is whatever divide the BSL by 5, roughly it's going to be how many units it is. I think it's like if it's 25, if the BSL is 25 and above, then you're starting at 5 units an hour, and it kind of goes down in 5s, roughly. So that's what we'd start with. Fluid. So usually in adult patients, we're going to give 10 to 20 ml fluid bolus, which is usually starting with normal saline, and then further saline over the next 2 to 4 hours to correct those fluid losses. The important thing for you to note here, and we'll get to more of this in a bit as well, is particularly in pediatric patients, that bolus is not always required. And if you're going to bolus them, usually start with 10 mils per kilo, if they're shocked or if there's signs of poor perfusion. That would be your experience.
Yeah.
And then the ongoing fluid treatment, there's quite specific kind of calculations that takes into account their deficit and their maintenance. And it's more than what we'll get to in this talk, but just know that the fluid management in kids is quite precise. And then managing the electrolytes. So to start with, the potassium is the main electrolyte that is going to be deranged. So you noted that the K on that gas was high, and usually the K does end up being a bit high, but the total body potassium store is generally quite depleted. So you will need to give some potassium, but usually wait to know what your level is. And it's 5 to 20 millimoles an hour depending on what the level is. And there's the protocol for that as well. And then obviously treat what the underlying cause is. So pharmacology related, so either non-compliance with the medications, other drugs interacting with the medications, or recreational drugs. So amphetamines, alcohol, that often comes into the mix. And then the other common things, obviously infection and surgical causes. And then the bottom thing is that the acidosis doesn't usually need specific treatment most of the time. So we're not usually in the habit of giving bicarbonate to treat the acidosis. When you treat the other things, the acidosis will fix itself. So we've got to manage the complications of the condition and our treatment. So actually I might just throw it out. What's going to happen when we give insulin? Sugar's going to go down. So potassium goes into cells. So potassium might go down. What else might happen if the sugar goes down too quickly? Cerebral edema, and why does that happen?
Because of the sudden change in osmolality.
Yep.
Some sciencey way of causing edema that way.
Yeah. So, if you think about it, so these people have got, you've got all of your normal electrolytes, you've got your salt, your potassium, and then suddenly they've also got all of this sugar in there as well. And so, to compensate, there's going to be fluid shifts from intracellular to extracellular to try and compensate for that. There's still usually going to be hyperosmolar, but you've got additional fluid in the extravascular space. And so then if you suddenly push all of that glucose into the cells, you're going to lose a significant chunk of that osmolality. And then that fluid is suddenly going to be relatively kind of hyperosmolar for a bit. And then to balance that all out, the brain, that fluid is then going to shift back into all the brain cells. It's just going to be moving where the solutate's moving, and then you will get cerebral edema. So that's kind of, it's all about where the solutes are moving, and then the fluid is going to follow. So yeah, that'll happen. So to
Inquiry
just keeping an eye on the sugar. So obviously the BSL checks every hour. Obviously you want to avoid significant hypoglycemia, symptomatic hypoglycemia, which is fairly self-evident, but then obviously you're not trying to drop the sugar too quickly to avoid adverse fluid shifts and cerebral edema. Other issues can be, if you correct things too quickly, there's this idea that you can get rebound ketosis. I didn't know that was a thing, but it can happen. And so your target is roughly to halve the BSL in about 8 to 16 hours. And if your blood sugar then becomes lower than 15, you actually kind of counterintuitively, you give sugar. Because what you're actually trying to correct not so much about the sugar necessarily, but you're trying to replace the insulin, so you switch off the ketone production, which is giving you the acidosis and promoting, the state. So you ideally you want to be seeing ketones falling, not just the sugar falling, and that's why you keep the insulin infusion going even after the BSL comes below 15. You add sugar because you want to be allowing that insulin replacement to then counteract all this ketone production. Fluid management's relatively straightforward in that it's your typical targets. You want to make sure that the patient's making urine. So a strict fluid balance chart is necessary, but an IDC, at least on our protocol, is not strictly necessary. And on the protocol, they've stated to not place an IDC unless you need to avoid sort of iatrogenic UTI, which is reasonable. Obviously, in the extremely unwell patients, ICU patients, maybe some surgical patients, an IDC is still appropriate. So just consider that. And multiple peripheral IVs are pretty much always needed because you're sampling lots of blood, you're running lots of different infusions, but you don't always need a CBC. And then the management of electrolytes.
21, please, staff base.
So we've talked about how the potassium usually starts off high, but total bodies usually deplete. And as soon as you start your insulin therapy, the potassium will fall. There's a point in the protocol to not start insulin unless you know what the potassium is. Generally, because it may already be quite low. So you just want to, if you're going to start insulin and the K is low, you want to be starting potassium at the same time. That's the main point of that. We might talk about hypernatremia with the other bit later. That's just the fabled sodium-potassium ATPase pump, which everybody remembers, I'm sure, right? The point of this is it's coupled to the sugar co-transporter. So it's just to show you how as the insulin works and sugar goes in, the potassium goes in too. We'll talk about creatinine sodium later. This is that same patient's renal function. We might load through this because it's 153. And this is just to show that their gas got better. And we'll move on. So TRAPS, first presentations, because they may turn up with, other symptoms, vomiting, abdo pain, infections, and it's not until you check the sugar that it's like, oh, we've got to deal with that as well. Older patients who've been type 1 all their lives, but they're older, or sort of that burgeoning group of kind of late onset autoimmune diabetes in older people. And then also subtle presentations. So like we talked about, biochemically, that pH doesn't have to be super, super low for them to still meet this criteria and require that treatment. So a good baseline is always just, if you're a diabetic patient, get a gas, check the ketones. Just make that kind of your automatic thing. And Dave Alexander was saying, if you haven't done it, the other thing to do is when you're getting, because everybody gets electrolytes done, pay attention to the bicarb on the electrolytes. It's generally speaking, if the bicarb's normal, it's unlikely to have a significant acid-base disturbance, but just one thing not to forget. Moving on to the second case. 79-year-old lady from home, brought in with functional decline, urinary frequency, confusion, some right arm weakness, thought to have had a UTI and started on oral antibiotics. Sounds like every patient we have, right? Examination, hot to touch, afebrile in AF, abdomen soft, non-tender, GCS 13. Still same but different, right? And then type 2 diabetes was on metformin up until 3 weeks ago when the GP stopped it. It was because of acute kidney injury. Well, don't ever forget glucose. They checked it, and it's high.
Wow.
Shock horror.
Wow.
Glucose was 49. So what do we? Just a guessogram. What are we dealing with here? No prizes again. Sorry. This is the sugars. Okay. So HHS, hypoglycemic hyperosmolar state. Is a bit like Betty White's. Older patients, they're a little bit dry usually, and they're very salty. This quote is actually misattributed. This is not her quote. Why do people say grow some balls, etc., etc.? That's it's a popular internet meme, but she didn't actually say it, which disappoints me to no end. Betty White's pretty cool. But yeah, so she's HHS, like Betty White, older patients, and it's always kind of floating around, but kind of will surprise you if you're not thinking about it.
Wait, who did say it?
Some comedian named Shen Wang, a young Chinese person. So I couldn't get further from Betty White, apparently. So the definitions, BSL, so 33, so quite a bit higher than for DKA. The osmolality is going to be 320 milliosmoles. If you can tell me what the normal range of osmolality usually is about. 290? Yep. Yeah. And then the other one is not in DKA, right? So pH is usually greater than 7.3, bicarbs greater than 15, and minimal ketones. So you can have a little bit of ketones just from having a bit of vomiting or being dry. And this one is because there's enough insulin around that they don't become ketotic, but there is still a bit of an insulin resistance happening. And so they still get this hypoglycemia, you still get the osmotic diuresis, making them hyperosmolar, and you'll still get electrolyte losses. Predicted serum osmolality. This is the formula. Has anybody seen this before? Probably not. So a lot of the fellowship guys will know how to calculate this because this is one of those calculations that we learn how to do. 2 times the sodium plus the urea plus the sugar. And in specific circumstances, you have to add the alcohol as well. Maybe think about using it in your next dry, salty patient. And then the other important correction is to think about the corrected sodium as well. There's a few different formulas around. The easiest is just sodium plus a third of the sugar. And that's because there's a measurement area because of the osmolality involved with the sodium and the high sugars. So, for example, this patient, when they came in, if we give you, where's our sodium? Sodium 131, so a little bit, if you didn't think about the corrected sodium, you'd say, oh, they're a bit hyponatremic. But Dave, do you want to calculate the corrected sodium for this person?
Plus a third of the glucose.
Yep.
So a third of, let's say, we say it's a third of
15.
about 15. So yeah, 140.
About 146, 147, 145. So they're actually, borderline hypernatremic. The point to bring up there is that if you've got a patient with HHS and their sodium to start off with is kind of normal range or high normal, then they're going to be very hypernatremic. It's just one of those things to be aware of, and it may alter your fluid choices. And then we can calculate the osmolality, but we might blow through that for the time being. This patient's osmolality ended up being 350 odd. So similar problems in that you've got an insulin resistance, you've got osmotic diuresis, and you've got electrolyte losses. So we treat with insulin and usually less than with DKA. So most of the time you'll start at 3 to 4 units with blood sugars that are usually in their 30 pluses. And with the DKA protocol, that sort of blood sugar level would usually require starting at 5 or above, right? So a little bit less insulin, maybe half. Their fluid deficit's usually heaps more than in DKA. And so they still need a fair amount of fluid, but you have to be more careful with these ones because they're usually older patients.
And if you've got someone who you think is quite hypernatremic, what are your fluid choices with that?
I still usually start with normal saline unless it's severely hypernatremic, because your normal saline will still be relatively hyperosmolar compared to their serum. But you may, after the first or second bags, you may really need to be thinking about switching to half normal saline, depending on how their sodium is downtrending or not. And then electrolyte management, still need to replace your potassium, and as we've been talking about, sort of keeping an eye on the sodium. And then aggressively hunt for an underlying precipitant for these patients. And given that they're generally much older, more comorbid, their mortality from this condition is actually quite high. So you need to be quite aggressive in trying to hunt for a cause. Again, with your treatments, you're not trying to drop the sugar too quickly. Strict fluid balance and fluid reviews, and these patients, because they're so hyperosmolar, they're quite at risk of venous thromboembolism, and so DVT prophylaxis is a must. And so if corrected sodium is above 145 after a couple of litres of normal saline, then you want to be switching to a half normal saline solution.
Do you guys just use Hartmann's?
You could use Hartmann's as your initial solution. And that would probably...
It would it wouldn't be any better than normal saline.
In the initial treatment, no. And I think the other thing about Hartmann's, there's a bit of potassium in it too. So you may, I think
there's a bit of lactate.
there's a bit of lactate too. So normal saline is always a pretty good to go. So the traps are not thinking about it in the mix of this patient looks like every other patient I've got, and trying to hunt for the other problem.
Comparison infection and not.
Yep.
Yeah.
And then also maybe potentially being too aggressive with the treatments in a patient that's generally pretty fragile to start with. And then very quickly, 24-year-old female, history of mental health issues, comes in status, not better with midazolam, airway is looking like a problem, and the reg is drawing up propofol for an RSI, and the nurses check the laryngoscope and then checks the BSL, and it's low. ABCD, don't ever forget glucose. Really easy to treat. Hyperglycemia, a bit like Nora Jones. She's lovely, but a bit boring. I really like her. Anyway, BSL less than 4 and symptomatic. Gives you sympathetic response, so tremor, sweating, palpitations, and then symptoms of low CNS glucose, so seizures at the bottom, irritability, LOC. I mean, you guys know how to treat this, so we might not go through this too much. But one of the traps is all the patients on beta blockers, they kind of don't have that response necessarily they don't get that sympathetic response to hypoglycemia, so you can miss it very easily. And then the other trap is just forgetting to check your glucose, I guess. Any other pearls from the hypoglycemia?
In children, you can get a hypoglycemia. Just think of the cause. Often in adults, it's that they're diabetic and they've misjudged their insulin, or they've taken an overdose, or it's a medication issue. And very rarely it's due to prolonged fasting. But in children, particularly very little children, the differential is a little bit bigger.
Seek underlying cause, in adults, medication toxicity or misadventure, sepsis, and very other rare causes. Just so that you know, there's protocols. Any questions? I was going to come in very soon and kick my ass.
Just a quick one.
Yeah.
Are there 2 different formulas for the corrected sodium? I just saw there was one that
so
had
some people will subtract
Minus
5 to
5.
10 off of the BSL, then divide by 3. On our protocol, it's just divide by 3. That's probably not going to make a huge difference, but just so you're aware that there's probably a bit of variability. It won't make a huge difference in clinical practice. Thanks. Do you guys want to take those sugars out to the board, to the floor, and I will forward you an email with Sugar Mama by Beyonce. Thanks.
Thank you. And if any of you guys had any feedback on this care.